Good afternoon and welcome to our quarterly lecture series for insurance executives, physicians, and patients. I am Dr. Galit Hakim, Vice President of International Healthcare Partnerships and Insurance Development at Baptist Health. It is my pleasure to welcome all of you to this informative presentation. I would like to extend warm greetings to our friends across Latin America, the Caribbean, and everyone joining us today. During this interactive presentation, you will have the ability to ask questions via the Q&A feature located on the bottom of your screen. Our moderator today will be Dr. Roger Rivas, Corporate Vice President of Baptist Health International. This afternoon, I have the distinct pleasure of introducing Dr. Felipe De Los Rios and Dr. Italo Linfante, who will present an important topic titled Preventing Death and Disability in Acute Ischemic Stroke. Dr. Felipe De Los Rios is a board-certified vascular neurologist and medical director of the Comprehensive Stroke Center at Baptist Health Miami Neuroscience Institute. Dr. De Los Rios received his medical training at Universidad Peruana Cayetano Heredia in Lima, Peru. He completed an internship in internal medicine, followed by a residency in adult neurology at the University of Cincinnati and University Hospital in Cincinnati, Ohio, where he also pursued a neurovascular fellowship. In addition to his work at Baptist Health, Dr. De Los Rios serves as a volunteer associate professor of neurology at the University of Cincinnati College of Medicine in Ohio. Dr. De Los Rios has published extensively in his field of specialty. He has participated in over a dozen research protocols and has been a speaker in numerous conferences in the United States and abroad. He is a member of several professional societies, including the American Academy of Neurology and the American Stroke Association. Dr. Italo Linfante is our medical director of interventional neurology, neuroradiology at Baptist Health Miami Neuroscience Institute. He is also a clinical professor of radiology and neuroscience at the Herbert Wertheim College of Medicine at Florida International University. Dr. Linfante earned his medical degree from University of Rome, La Sapienza, where he also served as a resident in neurology. He then completed residency in internal medicine at George Washington University Medical Center and in neurology at Baylor College of Medicine in Houston, Texas. He served as fellowship in the neuroimaging branch of the National Institute of Health and NIH in Bethesda, Maryland, in cerebrovascular disease at Beth Israel Deaconess Medical Center, Harvard Medical School. He was the affiliate or faculty of neurology and cerebrovascular diseases at Harvard Medical School, where he trained in interventional radiology, neuroradiology, and neuroendovascular surgery. Dr. Linfante served as an associate professor in neurology and radiology at the University of Massachusetts section of neuroendovascular surgery and interventional neuroradiology, and was the attending physician in neuroendovascular surgery at Boston Medical Center. Dr. Linfante has performed over 10,000 endovascular neurosurgical procedures and treated over 1,000 cerebral aneurysms. He has participated in major clinical trials for medications and devices related to technologies to treat stroke and other cerebrovascular diseases. He has lectured nationally and internationally on related topics. Dr. Linfante has been a member of the editorial board of the scientific journal Stroke since 2002 and associate editor for the Journal of Neurointerventional Surgery. He has been an editor for several other peer-reviewed medical journals in neurosurgery and neuroradiology. He's the author of more than 150 scientific articles published in world-renowned peer-reviewed journals such as Stroke, Neurology, Neurosurgery, and the Journal of Neurointerventional Surgery. He has published numerous book chapters and books in stroke and cerebrovascular diseases, and he is a diplomat of the American Board of Medical Specialties in Neurology and Vascular Neurology, and a diplomat of neurovascular surgery for the American Academy of Neurology Surgeons. Please let's give a warm welcome to both Dr. Felipe De Los Rios and Dr. Italo Linfante. Thank you so very much, doctors, for joining us this afternoon in this lecture.
Thank you, Dr. Hakim, for that kind introduction.
Thank you for the great introduction. Whatever I say is going to be fine after this introduction.
Do you want me to start screen sharing?
Please do,
okay.
yes.
All
Thank
right. Let me do this. Okay, so I'm going to talk a little bit about the general highlights of ischemic stroke and why we're talking about it, what's the importance of it, and what we can do to prevent death and disability in it. And then Dr. Linfante is going to give us a whirlwind tour about the neurointerventional treatment options for this condition. So those are my disclosures. So when we talk about ischemic stroke, or about stroke in general, we're talking about really three main subtypes: ischemic stroke, hemorrhagic stroke, and then subarachnoid hemorrhage. And subarachnoid hemorrhage can be a different topic altogether that we can discuss at a later time. Dr. Hakim spend some more time on aneurysms and AVMs and things along those lines. But when we talk about stroke, thankfully, about 80% is ischemic stroke, which is when there's a blockage on one of the arteries that brings blood to the brain. And then an area of the brain is going to be deprived of blood and oxygen and will therefore be irreversibly injured or die. A smaller percentage, about 10 to 15%, is bleeding. And that's when an artery ruptures and there's blood that spills over into the brain tissue, the brain parenchyma. And then about 5% or less are subarachnoid hemorrhage. And clinically can sometimes be difficult to tell them apart. They both present suddenly with usually unilateral symptoms as far as weakness, numbness, or difficulty doing things, speaking, talking, engaging with your environment. Subarachnoid hemorrhage and intracerebral hemorrhage usually have more pain, more headache. But sometimes ischemic strokes can hurt as well. Usually it's painless, but sometimes there can be pain associated with it. But thankfully, they're relatively easily told apart by imaging, by CT scan imaging in particular. So in ischemic stroke, initially the brain looks normal, just like initially a dead person looks normal. But then as time goes by, you're going to start to see those changes of that brain tissue as it's being degraded and goes through that process. So initially, this ischemic stroke will look normal initially. And then hemorrhagic stroke, where there's blood inside the brain, this is that white within the brain parenchyma, that hyperdensity. And then subarachnoid hemorrhage is that hyperdensity in a different location. That's the subarachnoid spaces, which is seen here in the middle of that CAT scan. So CT scan really helps a lot with that. And we already talked about these percentages. Thankfully, and I say thankfully, 87% is ischemic because that's what we have best tools to treat and prevent stroke. So stroke is very common. It is the 5th cause of death in the US, it's the 2nd cause of death in the world, I should say. And that's true for most of countries in Latin America. Stroke accounts for 1 of every 19 deaths in the United States. And there's about 800,000 strokes every year. There's about 7 million stroke survivors. And this is a leading cause of disability. So we estimate that 1 in 6 people would have a stroke sometime in their life. So how many people we have in the meeting now? Divide that by 6, and that's what's going to happen. It's just statistics. It's a common disorder. 1 out of 5 women will have a stroke sometime in their life. So most of us will hear, if we don't already know, someone or a relative that has suffered this condition. And one thing is dying from disease, but the other one is surviving with disability. And we measure disability in the form of DALYs, which is disease-adjusted life years lost, or disability-adjusted life years lost due to a disease. So this is how much productive life you lost because of that condition. And stroke is one of the leading, second leading cause of DALYs around the world. And you can see how that has been changing. There has been some increases in ischemic stroke, especially in low to middle income countries. And this is what I was talking about, disability-adjusted life years. You can consider 1 DALY thought as 1 year of healthy life lost, and you calculate that as your years of life lost versus plus your years lost due to disability. So that's adjusted to the life expectancy in each country. And this has a huge economic burden. And the indirect and indirect costs, 45.5 billion. There's the mean expense per patient for direct care. This is in the US, about $8,000. And this is going to increase because population age increases, and this is a condition that is associated with aging, but also with lifestyle changes and diet changes that the world is going through. Most of the cost comes from for patients greater than 80. Total cost in 2035, you can see what is projected there based on 2015 US dollars. But the good news is that about 80% of stroke is preventable. And not only is it preventable, it is also treatable. But there are some caveats about treatment that I will go through, but the bulk of it can be prevented. So that's the good news. And what can you do to prevent a stroke? And this is what we reinforce at the good, well office visits and primary care when you are in your middle life and later. And these are good habits in general that we teach, and maybe most of you will be familiar with. And one is checking and controlling your cholesterol, eating better, meaning more fruits and vegetables and less red meats and sweets, keeping a healthy weight, being active, managing and checking your blood pressure, the silent killer, right? If you don't measure it, you don't know that you have high blood pressure. So you have to measure it regularly. Controlling sugar, your blood sugar, and checking it regularly as well. You might not know that you're having prediabetes or diabetes. And then avoiding, things that are known to increase your risk of stroke, such as smoking and regular alcohol drinking. So when we talk about exercise, it really is about regular exercise. So we're talking about doing exercise about ideally 4 days of the week. It depends a little bit regarding the intensity of the exercise that you do, but it's regular exercise what lowers your cardiovascular risk. Even if you don't lose weight, it's not related to weight. Even if you don't lose weight, regular exercise will help maintain healthy arteries and a healthy heart and decrease your risk of both cardiac and cerebrovascular disease. But it has to be regular exercise. Any type of exercise that you like. The type of exercise doesn't matter as much as the frequency of it. And then your blood pressure. Now we're really looking at elevated blood pressures, even in the 120 to 130 range. So normal is less than 120 over 80. Before it was thought, 140s, is just starting to be hypertensive. No, between 120 and 130, you're starting to be hypertensive. So you have to take into account that the numbers, the normal values, and what we consider normal has been changing over time. And normal is less than 120 over 80. And that's resting blood pressure. And then when we talk about stroke, I'm going to shift gears a little bit and talk about what causes stroke. So stroke these are the main categories of what causes stroke. Atherosclerosis, which is fat deposition on the arteries, is about 13%. Cardiac reasons, atrial fibrillation, dilated cardiomyopathy, CHF, is about 30% of all stroke, and arrhythmias take a leading role on that, atrial fibrillation in particular. Small vessel disease, which we call microangiopathic, so damage to the smaller arteries over time because of lack of exercise and high blood pressure, is about 12%. And then there's some other causes, tearing in the arteries, 4%, unknown, where we don't have a specific cause, a quarter of the time, almost 25%. And then multiple causes or specific causes on a smaller percentage. And this is important because there's a lot that can be done to prevent stroke beyond the basics that I just mentioned: exercise, diet, glucose control, blood pressure control. When you have some of these other categories, specifically atherosclerosis or cardiac, there's additional things that you have to do to lower your risk of stroke, of having another stroke, to a higher degree. And some of those are, for example, if you have carotid artery stenosis or blockage of a carotid, is cleaning that carotid if it's causing a stroke. And that has to be done timely. So if you are able to do that within the first couple of weeks, specifically, it really helps lower your risk of another stroke, because most of the strokes that are going to recur are going to happen early. So the earlier that you get to it it's the best interest for the patient. So we really want to hear about those cases, as soon as possible, so that if a patient requires transfer to a higher level of care or transfer from one hospital to the other, that can be arranged and done promptly before the patient has a second event, which is what you're trying to prevent. The same thing with cardiac, starting anticoagulation or other things, closing PFOs, things that the patient may need. And when we talk about acute stroke management, so say the person already had a stroke, there's a few things that we can do that can help prevent lifelong disability and permanent brain injury. And this is a simple diagram that really showcases what the foundation of acute stroke care is. And here what you have is the artery. So this is, you're just showing the internal carotid artery going up into the brain. And this is going to bring blood, obviously, to the brain tissue. And there's different arteries and smaller arteries that branch out as you go into the head that bring blood to the head. And when you have blockages, especially if you have blockages early on the bigger artery, so just as it's starting to branch, what you can see is that there's a lot of brain that's going to be impacted here. And let me see if I can put my highlighter here. I don't know if you guys are able to see that yellow marker there, but there's a large area of brain that's going to be impacted when there's a blockage. And the person is going to have symptoms because that area is not getting enough oxygen to function. So they're going to have weakness on one side, inability to speak. The eyes are going to move in one direction. But that tissue is not dead yet. It's injured. It's not working properly, but it's not irreversibly injured. It's not dead. And if we're able to open the blood flow again, then that tissue is going to get better. And the sooner that we do it, the better the outcome is going to be because the less of that tissue is going to be injured. So in this case, for example, there's a blockage on this artery and blood is not going to this area. There's some blood that goes through smaller side channels, which we call collaterals, that allow for brain tissue to survive a little bit longer than brain that only gets blood from right around that artery. So the brain that gets blood from right around that artery is going to die very fast in the range of maybe an hour or two. And it's very hard to say that unless you're really close to the hospital and the hospital is able to deliver treatment very fast. But there's some other areas further out from that blocked artery that receive some blood from other arteries. We call that collateral again. And that can sustain longer, sometimes a day or longer. But as more time goes by, more brain cells die. So it's very important to have the tools to open that artery as soon as possible. The sooner we do it, the better the outcome. And we many times usually measure that in the range of minutes and hours, up to a day in some cases. And I'm going to just talk briefly about the medication that we use, and Dr. Linfante is going to talk about the procedures that we use. But the medication that we use in the acute setting is called Alteplase. We can also use Tenecteplase, which is an off-label indication for stroke, but many centers are using it, and we're going to start using it very soon here at Baptist. But what this medication does, and I'm going to, okay, here we go. What this medication does is exemplified in this video. So if you have an artery, as time goes by, fat accumulates on the artery. That's called atherosclerosis. In this case, that's what's happening. And those plaques can rupture and blood can start pulling to try to repair that rupture, and clots form, right? So a piece of that clot can either block completely the artery or it can dislodge and move upwards downstream on the artery and produce a blockage. And you can see here the collateral flow. So that's blood that's going through other arteries, that's bringing blood to side channels to the area of injury and maybe prolonging the life of that brain tissue to allow us to give the medication. But as soon as there's a blocked artery, then tissue is going to start to be affected. Some tissue is going to die right away, especially the tissue that's right around that clot. And some other tissue is going to be injured, but salvageable if blood flow can be restored. And that clot is produced by fibrin, which are the strands here that keep that clot together, and platelets, of course. And plasminogen is a component of the blood that can destroy that clot, that fibrin, but needs to be activated. And this medication activates that plasminogen to destroy those fibrils and dissolve clots. And if you're able to give it in time, then blood flow can go to that area of the brain, and then that penumbra is saved and the patient improves. And the longer we take, the bigger the stroke irreversible area of damage, and then the patient doesn't do that well. So time is very important for this medication. Usually we want to give it within 4.5 hours of when the patient was last known well. So very short time frame. Patients have to identify that it's a stroke quickly. They have to go to the right facility quickly, and the facility needs to know how to treat stroke patients to deliver the treatment within that time window. The sooner, the better. So centers that do these regularly, that do this well and have protocols in place, like ours, can give this medication in 22 minutes, 25 minutes. The national goal is less than 60 minutes. So you can see how the time frame is short. For thrombectomy, we have a little bit more time because those patients generally have more collaterals, as the clot is usually more on the bigger arteries, the ones that we can actually reach and remove clots from. So Dr. Linfante is going to talk a little bit more about that. And what is the impact of this medication? So out of 100 patients that have an acute ischemic stroke that receive this medication, we can really benefit about 32%. So 13% of those will be back to normal, like they have a second chance at life. They will regain the brain injury that they were destined to have, and they can return to their work and family and friends. And about 19% will have some disability. They will not go back all the way to normal, but they can still function independently and might need some help with a few things here and there, but they can by and large be alone and do the things that they need to do without assistance. But then all the people in white won't get benefit from this medication, and they could get benefit potentially from that procedure that Dr. Linfante is going to talk to you about. And the medication does have a risk of bleeding, and those are the people here that have a dash on them and are in red. And those people that are in red are people that are going to die from complications of the medication, namely bleeding. So the medication has some specific indications and contraindications. We don't give it in people that have a high risk of bleeding, and we only give it for those that are having disabling symptoms, because there is a risk with this very potent clot buster destroyer. So I know we're very short on time. It's a very direct presentation, and we're going to have some more questions at the end. So I am going to turn it over to Italo, if Italo is ready. I know that he's getting some phone calls about a case right now, so hopefully he'll be able to talk to us. Italo, do you have some time, or do you have to go and actually save someone's brain right now?
I'll try it. Eventually I might be interrupted because that's just actually a stroke.
Yeah, sure, of course.
Getting worked out, but I'll try to do my best. So thank you very much, guys, for inviting me. Thank you, Felipe, for the wonderful introduction. It's going to make my job much easier. Let me see if I can get my slides up. If you can see my slides.
You can see them, Doctor.
Can see them?
Yep,
okay,
we can.
So so thank you, Felipe. Thank you, Galed and Rogelio, for inviting me. It's always a pleasure, Dr. Hakim and Dr. Ribas. So stroke is a very important topic because the treatment has been tremendously advanced in the last few years. So we're really changing a disease which used to be a death sentence into a disease which is treatable. Thank you to the work of amazing physicians and scientists like Dr. De Los Rios and many others. So I'm going to talk about the endovascular treatment of this condition. These are my disclosures. Like Dr. De Los Rios just mentioned, we're talking about ischemic stroke when there's an occlusion of an artery. This is an angiogram, and you can see a nice middle silver artery, internal carotid artery, middle silver artery on one side, and there's a blockage here that blocks the flow of blood into this section of the brain. The section of the brain eventually will be damaged greatly. So I like to show these slides before I give my presentation so people have an idea of what we're talking about. So when you talk about large artery occlusion, so an occlusion of a large vessel of the brain, you're talking about a high percentage of death and disability. In this case, there's a neurological examination in points that we use called NIH stroke scale. And having an NIH stroke scale of 17 or above equals a risk of death or disability of about 84%. These are all data from the NCTPA trial. And that's the typical patient that comes in with a middle silver artery occlusion. They have an NIH of 17 or above. Patients who have a malignant middle artery occlusion have 80% mortality, even if they are 18 years old. If you have an internal carotid artery occlusion, you're talking about a 73% mortality, and only 3% will eventually do well. If you have a vertebrobasilar junction occlusion or vertebrobasilar occlusion, then you're talking about a 90% mortality. So, but in 2015, the world has changed because we published 5 randomized clinical trials on these are randomized clinical trials controlled, so level 1A evidence, the best possible evidence, by also publication in New England Journal of Medicine. So this was one of the first one. 5 trials were published. Escape, Extend IA, Swift, Prime, which we were involved, and Revascat. So what this trial shows that when someone comes with a patient comes with a large artery occlusion, if you take them to the cath lab and open up the artery like we do for STEMI, you have a high chance of recovering this patient's disability. In fact, for instance, in this trial, Swift Prime, the group that were treated endovascularly, 60% of them had a normal neurological examination and function 3 months afterwards, and only 33%, so double the patients who were not treated with endovascular treatment. And this is I'm going to show you this data later on. Basically, a modified ranking scale, which is basically a disability scale. At 0, no symptoms, and 6 are patients who unfortunately didn't make it. And you can see that if you use a thrombectomy, the percentage of patients with a ranking of 1, 0, 1, or 2 in this case is much higher, which is no disability, is much higher than patients that were just treated with medical management. So it was a great victory for endovascular treatment. And why we have these amazing results is because the technology allows us to recanalize the artery. And in fact, if you plot percentage of recanalization that we call the TICI, is a TICI scale, 2B or 3, which means complete, almost complete or near or complete recanalization versus good clinical outcome, there's a direct correlation. So the highest percentage of patients you are able to recanalize the artery effectively, the higher is the chance that you achieve good outcome. And then we went to the DAWN trial, which is a trial that was published a year later, in which we showed that we can extend this window up to 24 hours by sophisticated imaging. So in the trial, patients were randomized to medical management versus endovascular thrombectomy to 24 hours, but they need to have this type of imaging, which is CT perfusion or other type of advanced imaging, which actually show what Dr. De Los Rios showed you before, the so-called tissue risk. So when an artery is occluded, some part of the brain dies very quickly, a very small one, and the rest of the brain, as so-called penumbra, is kind of underperfused, and this brain is kind of a risk. And so if you intervene early and you take the clot out and recanalize this penumbra area, you can save the brain. So with this advanced imaging, you can kind of select patients that are good candidates for endovascular treatment up to 24 hours. And the data were, again, there's tremendous statistically significant superiority of this treatment compared to medical management, up to 24 hours at the symptom onset. And then another trial that was NIH funded, up to 16 hours confirmed pretty much the similar results. So even a later time point, you can take this patient to the angio room and have excellent results. Okay, so what happened? There was a shift from time window to kind of image to tissue window. Basically, instead of using a rigid time criteria to select patient for intervention, we use a tissue window based on advanced imaging, like I showed you before. The bad news, so all good news so far. The bad news, what are the bad news? Bad news is time is not on our side, and that's what we really want to stress in this forum, that we need to be fast, because if we're not fast, unfortunately, brain dies very fast. The same data that I showed you before, if you plot symptom onset to reperfusion time versus patient with clinical outcome, we have actually an inverse correlation. So the more time passes by from occlusion of an artery to recanalization of the artery, the less is the chance of achieve good outcome. And this was also published extensively by our colleagues, large meta-analysis with large patient, talking about 900, 1,000 patients data. But we plot time from symptom onset to reperfusion versus percentage of patients with good clinical outcome, and you can see that there's a large percentage of patients with good clinical outcomes here, modified ranking scale 0 to 2, and this decreases as time goes by. We also published on the same topic. We had these are randomized control trials. So the critics always say, oh, these are control data, it's not real life data. So let's have real life data. So we did that. So we published. Was an honor to be some of the authors in this endeavor. It's a large registry called NASA. These are real life data collected. And I have to say that I really want to congratulate Felipe and myself and many others. We're collaborating in a very large database. We are the third largest enrolling center, and is probably the largest database that has been collected so far. We're over 2,000 patients, thrombectomy patients collected already. So we have data on this patient, extensive data, and the data are the same. Basically, excellent outcomes with endovascular regionalization, endovascular thrombectomy. However, need to be fast. And what we publish in these predictors of good outcome, despite successful regionalization, is basically time. So the longer we wait to regionalize this patient, the worse is the outcome. And this is data that were published a while ago, so it's very well known. Just to give you an idea, there's a 9% increase in risk of death or disability per 30 minutes delay of successful regionalization. And there's also another more data published from the Stratis registry. So, like I said before, this is what Dr. De Los Rios mentioned, trying to go fast, because I might have to go to do a case. So there's a core and a penumbra, and then the core kind of progresses into penumbra, so that whenever you regionalize the artery, you block this core progression, and therefore the smaller is the final inflow volume, the better is the chance to have good clinical outcome. So how do we make this better? Technologies come to on our side. Some of us are involved in actually improving the technology that can give us such amazing results in the angio room. And we came up with this TK3 first pass effect. What does it mean? TK3 means complete regionalization of one pass-through device. So you go up with your tools into the middle cerebral artery of a patient, and you one pass, as soon as you pull the clot out, you have perfect regionalization. It's called TK3 first pass. So we studied this TK3 first pass effect and was one of the authors in this paper, which has become very important. And TK3 first pass effect give us the best outcome. So the faster you can regionalize the artery, the best is the outcome. So TK3 first pass. How do you achieve TK3 first pass? If you have good devices. So we are working on better devices. At the beginning, we used to use this balloon guide and stent retriever. So basically, you place a balloon guide catheter with a balloon here, and you have a retrievable stent. It's basically like a stent you can pull back. So the stent captures the clot, and then you have this point you inflate the balloon and you aspirate. So you do kind of flow reversal type of effect. So the flow, instead of the flow going forward from the carotid into the middle cerebral, it comes back to you because you block it and you aspirate. So flow reversal effect, balloon guide catheter, that's what we used to do at the beginning. But then we are moving more towards ADAPT technique. So ADAPT technique is basically you place a large bore catheter direct into the middle cerebral, and then you aspirate at this point. Or we can combine two techniques, aspiration plus stent retriever. So you go with a large bore catheter into the middle cerebral artery and a stent retriever. You grab the clot and you aspirate and you pull everything together. There are several devices. I'm going to go very fast on the devices. I'm going to show some data. There's some data that shows aspiration is very similar to stent retriever. I'm going to show some cases. 92-year-old woman, sudden onset left hemiplegia, slurred speech followed by decreased mental status, 92-year-old. Right hemispheric syndrome, NH of 21. So if 17 is bad and 21 is super bad. She had a T occlusion. So basically the internal carotid artery divides anterior and middle cerebral artery. It's called a T. So occlusion right there, which is horrible outcome in this case. You can see the brain. You can see here on the brain, there's a very large clot extending from the internal carotid artery into the middle cerebral artery here on the right side. These patients, of course, 92-year-old has very tortuous vessels, but with the technology we have nowadays, we actually navigate our tools in this very tortuous vessel. You can see here the artery is blocked at the T level. Hold on a second. Can I call you back in 1 second? Go back 1 second. Okay, yeah. So, so we're able to, you can see, was able to navigate this very large bore catheter all the way to the middle cerebral artery. With the first pass, and we recanalize the carotid. Now we have a middle cerebral artery occlusion with the anterior cerebral artery now is recanalized. And then second pass, we recanalize the whole middle cerebral artery. This is a large clot that we pulled out. Basically, it's like a cork here, and then there's a large clot stagnating into the internal carotid artery. We're able to aspirate, and the patient did very well. Now, the patient, 95-year-old, atrial fibrillation, was not recognized by stroke by EMS. Most of the time, what Dr. De Los Rios, very capable, was able to do, organize a system of care which is extremely effective. So basically, the ambulance gets the patient at home, and we use a fast TD score, basically fast face, arm, speech. So if the patient has deficit in face weakness, arm, and speech weakness, then you get a score. And if the score is suspicious for a stroke, then we get called right away. So we get activated from the field before the patient comes to the emergency room. In this case, with no activation from the field, when I read a patient in the emergency room, they had left hemiplegia, gagged and deviation, decreased level of consciousness, NH was 18, and one M2 occlusion, very tortuous aorta, as you can see here, and very tortuous carotid. I'm going to show you a video as this device can actually work. So you can see where in the carotid, and then there's a small catheter that we advanced, there's a wire that passed the clot, small catheter that we advanced, and then over the catheter, we advanced this gigantic device, it's almost as big as the middle cerebral artery, right in front of the face of the clot. So basically kind of block the middle cerebral artery with the device and aspirate very effectively from the clot directly from the middle cerebral artery. So you can see here, this device in the middle cerebral artery. And despite the fact that this 95-year-old that is extremely tortuous vessels here, we're able to navigate our tools all the way up into the middle cerebral artery. We were able to obtain great recanalization in this case with good outcome. So this is what happened to this 95-year-old, atrial fibrillation, age of 18, and 1 to 2 occlusion, tortuous. So CT to groin, 84 minutes because she had to be intubated. There were very sick patients. Groin to first pass. By the time we actually access the groin to the time we do the first pass, 90 minutes, so very fast. CT to first pass under 3 minutes, going to recanalization 20 minutes with a TK2B score. And patient did great in 3 days, an stroke scale of 6. So from that to very mild disability. Now the patient, 72-year-old, atrial fibrillation, left hemiplegia, neglect, hernias deviation, decreased level of consciousness, and age of 17, ICAT occlusion. You can see here there's no flow into the internal carotid artery, so horrible prognosis in this case. And there's a video here too. Yeah. So again, able to, with a small catheter, we go up into the middle cerebral artery. With the wire, we pass the clot. And then we advance this gigantic catheter into the middle cerebral artery very quickly. This is real time, guys. And pull the wire and perform thrombectomy. We recanalize the entire internal carotid artery and entire middle cerebral artery. Follow up, 72-year-old, an age of 18, ICAT occlusion, door to CT 15 minutes. That's really the amazing job that these guys are doing in the emergency room. Patient got VTPA, door to groin 45 minutes, groin to recanalization 35 minutes, TK2B. So basically almost complete recanalization after 2 passes, 3-day NH scale of 8. 84-year-old, atrial fibrillation, lasting normal the night before. This would not be a candidate for intervention up to 4 years ago, but now we do. Hemiplegia, aphasia, hernias deviation, decreased level of consciousness, NH of 17, left and 1 occlusion. You can see in this case, because we don't know when the stroke happened, we do our advanced imaging, they could tell us that the area of brain tissue damage is actually very small. And and the area of tissue at risk is very large, about 107 millimeters. So if this tissue would all be dead, this patient will never make it. With 107 cc's of infarction, patients don't do well. So we have this mismatch, basically this tissue at risk that we could potentially save if we are successful with our intervention. And there we go, similar technique, place a large bore catheter into an carotid artery, and I use another catheter to reach the middle sleeve artery. In this case, we use a combined technique, so centrifugal plus aspiration, and good recanalization of the middle sleeve artery of all branches. 84-year-old NHO17 left lung occlusion, door to CT 20 minutes, door to groin 45 minutes, groin to recanalization 25 minutes with TK3 for recanalization, and NH to axilla 3 days is 4. Then the NH of 3 or 4 afterwards, it means that this patient will do very well. Hold on. Can you guys hear me?
Yes, doctor.
Yeah. So let me finish because I have to go upstairs. So let me go to the conclusions because I need to run. Sorry. So endovascular treatment is a very powerful treatment. If I can make a very provocative statement, we are under treating, because we have our number needed to treat is 4 to 1 or 5 to 1. It means that we can treat much more. And in fact, we are extending with Dr. De Los Rios, we are actively working to extend the window, the number of patients we can benefit from this treatment. Basically, if patient presents with a large core, perhaps there are good endovascular treatment as well, and we're working on that. There's several trials. First pass devices, we're working on that. We're working on straight to angio, perhaps bypassing CT and go straight to the angiography room. We're actively working on neuroprotection, basically giving medication to extend the penumbra, so that we can actually have better results. So this field is rapidly moving. And the present, I would say, is bright for patients with stroke, but I think the future will be even brighter. And then I'll thank everybody, Felipe and the best team and all the nurses and techs that help us every day in taking care of patients. I can take maybe one question and I have to run upstairs.
Dr. Linfante, we completely understand if you need to run. I know that time is the essence, as you guys have taught us before. I think that you have been extremely generous with your time. Thank you so much for that presentation. It's your call. We would love to have you. If not, you're free to go as well.
Yes, don't worry, Italo. I'll help with the questions.
Yeah, I think Felipe can answer all the questions.
Thank you so much, Dr. Infante, for everything you do.
Thank you, guys. I appreciate it.
Thank you.
Thank you.
So, Dr. De Los Rios, thank you so much for helping us with the Q&A. Dr. Rivas is going to do us the honor of actually moderating. There is a slew of questions that you're going to get bombarded with. So, Dr. Rivas, your floor.
So we have arranged, Dr. De Los Rios, of questions. We have all types of professions that have logged in here, but this one specifically from Celeste Bonilla from the Dominican Republic. She's a broker, and they're asking what are the principal symptoms for an acute stroke, an ischemic stroke?
Yeah, sure. So the symptoms, the symptoms are negative symptoms, we call them. So you lose things, meaning and they're sudden. So the person was fine, and then the next minute they're not, and they lose things. They can lose strength, so they can be weak, have a difficulty raising an arm or a leg. They can lose vision, speech, to the ability to pronounce speech, but also could be the ability to understand speech, lose balance. So it's negative things. People lose things, and usually it affects one side of the body. So they can lose strength on the right arm, but not on the left, or lose balance where they're leaning toward one side. So I think that's the hallmark. We use the acronym FAST from the American Heart Association. You can look at it online as well. And FAST means face. The F is for face. So one side of the face could be weak. A is for arm. It could be arm weak. So if you ask the person to lift both arms, one will go down and the other one will stay up. It could be the leg instead of the arm. S is for speech, so speech problems. And then the T is for time, because as you've heard, time is so important. So that kind of summarizes it. That detects about 85% of all strokes. If you remember fast, you can detect up to 85 or so. I hope that answers the question.
Thank you, doctor. Going on to the next one, we have a question from Carolina Sanchez. She's a medical student from Costa Rica, from UIA. Thank you, Carolina, for the question. Doctor, why do you recommend RTPAs versus others? RTPA?
Yeah, so Alteplase is the one that has had the studies done. Really, there's been studies with other thrombolytics, the older generation thrombolytics, streptokinase, urokinase. They didn't work. They just didn't work for stroke. And you cannot take the literature from cardiac straight to neuro because it doesn't work that way. The side effect profile, the risks are different. So Alteplase has been the one that has been studied the most since 1995, is the only medication that currently have on-label approval. Tenecteplase is a new medication that has had quite a few studies recently. And we have no doubt that it will be approved for stroke in the near future. And there are a few randomized controlled trials that are still pending. TWIST is one of them, and Timeless is another. Hopefully they'll be done in the next year or so, but with the data that we have so far, many are already starting to use it off-label, and that will be the case with us. We're going to start using it next month, well, a little bit over a month, and we'll be using that as our standard of care, but it's not FDA approved yet, and that would be Tenecteplase.
And can you, doctor, run us by how this field has changed so dramatically, right? We only had a 4-hour window and then an 8-hour window and then growing. Can you explain a little bit so that the folks here know?
So we first started, the studies were done with 3 hours. Within 3 hours, the 1995 NINS Alteplase study, which is the first one that really led to approval, was done within 3 hours of symptom onset. And we knew from the beginning that time was a very critical piece of this. So if we wanted to show a benefit, we needed to treat patients before the damage was done. And prior to 1995, really, the neurologist was not much in the emergency room. You wouldn't get a neurologist to go to the emergency room. We would be in the office and we would come to the hospital to, see the consults the next day or so. But it was hard. It was a big shift to get people. You wanted to treat someone in the emergency room within an hour, with this medication, and you wanted a neurologist to be there. So, things were changing. It was a big change for the field, but they choose 3 hours to be on the safe side there, that the study would be positive, and it was. And what we've been doing since then is more studies, trying to see how far we can push this and still get benefit. And we know that there's benefit up to 4.5 hours. Between 3 and 4.5 hours is still off-label, at least in the US. In Europe, it's on-label, but in the US, it's still off-label. But we know that it works up to that time period, but it works less. So if you give treatment at 2 hours, 1 hour, it works much better than if you give it at 4.5. So there's still benefit, but it's not as much. And now we have even 2 studies that show benefit beyond 4.5 hours for a selected small group of people. And those can be selected by MRI for those that are wake up or found abnormal, or you can use perfusion imaging to select those that have a penumbra and cannot undergo thrombectomy for whatever reason. And that's called the Extend TPA trial. And that goes up to 9 hours, but on selected cases.
Thank you, doctor. And right after that, there is a possibility of putting the patient on a plane, or how quickly can we move the patient?
Yeah, so I saw there was a question about Alteplase. If you want to give that medication as fast as you can. So if the patient is eligible for Alteplase, they can receive that medication. You have the medication on your site. You have the CT scanner and the other things that are needed. Absolutely, give that medication. Do not wait, because treatment is directly correlated with how fast you open that artery. So yes, give it right away. And then if the patient is a candidate or a potential candidate for thrombectomy, and they can get to us within a reasonable time frame, then yes, send them right away as soon as you can. But I would do the TPA first. That thrombectomy has been shown to work up to 24 hours in some cases, but the same. The sooner you do it, the better. So yeah, we have some protocols set up, Roger, with with the Dominican Republic. We've been working there, and we're working with Panama. And there's some protocols that can be set up so that those patients can be rapidly identified and then transferred rapidly to potentially receive their treatment here, or you can, with whatever site hospital that you're working with. So that they can be identified appropriately fast and then transferred to the site that can do the treatment fast as well.
And if Alteplase is not available, doctor, but they have other types of medication, something is better than not being able to.
No, the only medication that's approved is Alteplase. You could use the Nectaplase at the brain doses, not the cardiac doses. But beyond that, there's no other thrombolytic that I would use because they have not been shown to be of benefit. And there's risk of bleeding, intracranial bleeding. So you wouldn't even know what dose to use. So I would only use Alteplase. The Nectaplase you could consider as well. But beyond that, thrombectomy is the only other option. So a patient could qualify for both the thrombolytic and thrombectomy, or only for one of them. Maybe only thrombolytic, or maybe only the procedure, or both. So it could be either or.
Jumping back to your slides, can I ask you for a favor? If you can turn on and share your presentation again and show again the slide that you have with the Joint Commission Neurostroke Accreditation. And as you're doing it, maybe explain what is the importance of that, Dr. De Los Rios, and how where you're helping other places like Panama, so folks can understand how important that is.
Yeah, so I think you're referring to this slide with the accreditation there from the American Heart Association, and the Joint Commission can accredit facilities as stroke centers internationally as well. They accredit international centers as stroke centers. And that's important because one, you have the resources from administration and the hospital so that you can treat this group of patients appropriately. You have the tools for it. But also you highlight your hospital as a beacon, as a center that can treat these patients. Because if there's no pre-hospital algorithm that's well developed, what could happen is that a patient that is suspected of having a stroke is taken to the wrong hospital. And that's a catastrophe, right? Because then the patient was maybe diagnosed appropriately at the beginning, but then they went to a hospital that doesn't have the resources, doesn't have the trained staff, doesn't have the algorithm, might not have the medication. And then the patient gets to the hospital, but doesn't get the treatment, or the treatment gets very much delayed. Once you reach a hospital, it takes about an hour, in the best situations, usually 2 or 3, to leave that hospital if you need care at another facility. And with 4.5 hours being the timeline for the medication, you can imagine if you chose the wrong hospital, then you're doomed. You're not going to be able to get this medication. The odds are you're not. So people knowing this is the hospital, if I have a stroke, this is the hospital I need to go, is very important for that community. And this is one way of obtaining that. You can you have the certification, you can advertise the certification, you can share the certification, and you can talk to your EMS partners and say, look, we are certified, we're ready, we have proof, we are the center to take your patients if you suspect they're having a stroke.
We worry so much about cancer, and we forget about all the vascular situations in stroke, and something that's so important. I think you nailed it when you talked about, how many, the possibility of the I would say the consequences later on that we always have to factor in as an insurance, as a person looking at the lifetime value of the patient and the lifetime possibility of having them not have any deficits. It's so important. One last question about carotid. There was various questions about carotid stenosis. What is the percentage that you look for the possibility of some type of surgery, whether interventional or whether it is open? And if you can talk a little bit about diagnosing it and what should we be doing obviously to try to prevent the carotid artery
Yeah,
stenosis.
so I saw some questions regarding the exam as well. So carotid stenosis, we divided whether it's symptomatic or asymptomatic. If it has not produced any symptoms, we do not know, there's no cutoff as to what % of narrowing needs to be operated on. Right now, there's a study that's ongoing called the CREST-2 that will randomize people that have an asymptomatic carotid, meaning it didn't give them a stroke or syncope or anything like that. And they will be randomized to surgery versus medical management if the narrowing is 80% or higher. So even if you have a narrowing of 80% or higher, we are not sure if we should operate on it if it's not giving you symptoms, right? That doesn't mean you shouldn't treat it. You should treat it. There's medications for cholesterol control, sugar control, blood pressure control, avoiding tobacco. Yes, smoke, not the electronic cigarettes. Yes, they also worsen your vascular outcomes. So you should treat it, but not necessarily surgical if it's asymptomatic. If it's symptomatic, if there's a stroke and the stroke is deemed to be related to that carotid, we usually use a cutoff of 50%. If the artery is 50% or whereabouts 50%, then we do recommend intervention, surgery, as well as medical management to prevent stroke. But the sooner that surgery is given, the better. So within 2 weeks, ideally, but even within those 2 weeks, the sooner you do it, the more strokes, recurrent strokes you will prevent. So it's very important for us to hear about those cases early, because if they're going to come or if they're going to be referred anywhere, you want to talk about them early, because otherwise those patients are going to have an early stroke that that could have been prevented. So that's 50%. And there's some data that even some patients that have a smaller plaque burden could benefit. Depends on the patient characteristic, but 50 is the number that most vascular surgeons would be looking for in that situation.
I think more and more the DALY and everything that we do, and as many insurers here on this call, is that we need to take that into account more and more in the future.
Yeah, and the ultrasound, they were talking about hearing the exam piece. I know there was a question about that.
The stethoscope,
and
yeah.
It's not reliable. So you might hear turbulence, you might hear a bruit or so over the carotid when the degree of stenosis is not bad, because there's turbulence. And then as that carotid gets really narrow, then there's very little flow, there's very little turbulence, and you won't hear it. So it's not a very reliable indicator.
Thank you, Dr. Hakim. I don't know how he went through it so fast, but he went through every single question. Would you have a question for Dr. De Los Rios?
It is absolutely remarkable. I don't, because if I do, then we will have him for an hour more. It is important to mention that obviously time is the essence, as you guys have highlighted during your presentation. And more often than not, Dr. Rivas, you've noticed that sometimes when we get patients from abroad, we get them a little bit too late in the process, which today with the executives that are joining us and the medical directors from the insurance companies that are joining us, understand that that is not only bad for the patient, but is also bad for the business of insurance. So comorbidities and complications come to play, and then we are left with a patient that is not necessarily going to get better, but extend the length of stay in the hospital. So that is absolutely an important component that you guys presented.
And when we're talking about being open and available to check eligibility and benefits, I always remember what Dr. De Los Rios says, time is brain. That's right. So this is, I think, a good token for many folks to take back home, is that how do we make the processes, just like the doctors and the nurses are doing everything they can to save brain, what do we have to do as administrators and on the insurance side to make sure that we save brain and save dollars in the future? So, but thank you so much.
Absolutely.
So on behalf of Baptist Health International, Dr. Hakim and I would like to thank Dr. De Los Rios and Dr. Linfante for their informative presentation, and all of today's participants for your attendance. If you have any additional questions about today's presentation, please feel free to email them to us at BHIWebinars@baptisthealth.net. I repeat, that is BHIWebinars at baptisthealth.net. We will make sure to get any of those questions to the doctors and get them answered for you. We look forward to seeing you at our next quarterly insurance lecture series meeting scheduled for October 27th, 2021. Thank you again. Have a great afternoon. Be safe, be careful, wear your mask, and get vaccinated.